Thank you for asking me to comment about the COVID-19 pandemic and its impact on the UK Jewish community in my capacity as Jewish Medical Association UK Executive Chair. There's also a personal aspect. As Emeritus Professor of Immunopathology UCL, I'm only too aware that infection spread doesn't take into account national, social, cultural and faith boundaries, and in addition that the individual may vary considerably in their response to an infection. Thus, with the COVID-19 and the UK Jewish community, there are common features with other British people, they're distinctive features. Members of our community have been ill, but the first wave was near the festival of Passover. Our observance of the festival changed rapidly, and ever since then our religious authorities have taken on board an advice from their own professionals, and in addition to which they have made clear that there are specific needs as well as those that are required by the government. We are proud that members of our medical community also play a role not only in care, but in formulating policy. At the time that the festival occurred, we wrote to Jewish doctors and our healthcare personnel. Some were working with colleagues at the coalface, struggling with gaps in facilities, placing themselves at risk and coping with the stress of the unfamiliar. There were vulnerable members trying to stay safe and healthy against an insecure background, and trainees and students who had to change career paths and change responsibilities dramatically. We wrote that our community as a whole, as well as our professionals, have to be aware of the huge health and social care needs that have arisen nationally, and that this includes both physical and mental health. While we look at all patients with anxious families and anxieties equally, of course there are things that we can do for our members of our own community who are facing loneliness and bereavement in unusual circumstances. Many issues have been tackled within the community over the past 6 months consequent on that. Children face the same problems as others with regard to distance, not able to go to school. But in addition, arrangements for milah, circumcision of 8-day-old Jewish boys, has had to be adapted to limit risks for those attending. Family gatherings and festivals have been constrained, marriage ceremonies have been limited, and many Jewish communities have taken the opportunity to contribute generously to local charities in cash and kind, but our own charities face a very fragile future, and our care homes, residents and carers, suffered in the same disproportionate way as happened to others. The pandemic has thrown a very sharp spotlight on the relationships between faith, ethnic and minority communities in the mainstream society. Community appreciates consultations that are done at both national and local level, but often the initial draft consultation document unfortunately betrays that there are underlying prejudices. One of the biggest issues has been the way the communities with whom we share many common features, such as BAME communities, Muslims, Hindus, Sikhs, have suffered. This is all our problem, not theirs. It has involved their healthcare professionals so enormously that this should be a source of deep concern, if not shame. The first hypothesis must be that this has exposed and exaggerated unacceptable inequalities in British society. The Jewish community itself has, however, had its own distinctive pattern. During the early days, we modified our funeral practices, traditional bereavement patterns were changed, and our burial societies faced huge pressures. Our record-keeping, undertaken by the Board of Deputies, incorporated care homes and communities rapidly and in advance of those in the wider society. We corrected for age and inequalities. When the ONS data became accessible, it became clear the death rate of Jewish men in excess of the usual death rate between March and May is much higher per 100,000 than in any other faith group. Our demographic team at Jewish Policy Research are grappling with why this is, why more Jews have died attributable to COVID-19 in the UK than have died in Israel. Both as individuals and as an association, we are pleased that questions are being asked about how to mitigate future risk and reduce health and social inequalities. We look forward to continued closer cooperation in prevention. A key element in this is that it has to be not only personally, but also between all our communities.